Hi everyone, welcome to lesson 6.1, Healthcare Systems. So this lesson's all about health systems and really the aim for attaining universal health coverage. So we're going to discuss about what a health system is, the functions of a health system and how they're organized. We'll talk about how some of the financial parts of healthcare systems, but then I want to dive into some of the critical issues that health systems face, especially in low middle income countries. And then in the next lecture, we'll discuss how some of these might be addressed. So let's start off by talking about what is the meaning of universal health coverage. Well, universal health coverage is what we're aiming for everyone around the world. And so it means that all people have accesses to the health services they need, when they need them, where they need them, without financial hardship. And it's coming from a point of view that the full range of essential health services are provided, from health promotion to prevention, treatment, rehab, and palliative care. If we look to WHO, currently at least half of the people in the world do not receive the health services they need, and about 100 million people are pushed into extreme poverty every year because of out-of-pocket spending on health. And so we need to change that. So to make health for all a reality, we need individuals and communities who have access to high quality health services so that they can take care of themselves. They can take care of their own health and the health of their families. We need skilled health workers providing quality, people-centered care. And we need to look upstream to policymakers who are committed to investing in universal health coverage. If we think about universal health coverage, it's based on people-centered primary health care. And we're going to speak about the importance of primary health care. Good health systems are also rooted in the communities that they serve. And they focus not only on preventing and treating illness and disease, but also helping to improve the well-being and quality of life of their community members. So what is a health system? Well, a health system is the sum of many different types of organizations, institutions, and resources whose primary purpose is to improve health. And so these agencies plan, fund, and regulate healthcare. They provide the money that finances healthcare. They provide preventative health services. They provide clinical services, rehabilitative services, and they also provide specialized inputs such as education of healthcare professionals. An important sustainable development goal related to health systems is goal number 3, which is ensure healthy lives and promote well-being for all at all ages. And these are some of the targets under Sustainable Development Goal number 3. Now, I'm not going to go into detail in every single one of these targets, but if you look in the textbook on page 121, it does go through some of these. So for example, target 3.1 is looking at by 2030 to reduce the global maternal mortality ratio to less than 70 per 100,000 live births. And so in relation to health services will have to play a central role in the provision of family planning services, prenatal classes, and emergency obstetric care if this goal is to be met. Another example would be target 3.6. 3.6 is to halve the number of global deaths and injuries from road traffic accidents. And so health systems will need to work with other agencies. These efforts will need to encourage better driver training, safer vehicles, and appropriate helmet use, better traffic enforcement, and so on. So you can see how there are many targets with respect to Sustainable Development Goal number 3 that health systems need to be involved in. So what are the primary functions of a health system? Well, health systems have 4 main functions: to provide health services, to raise money that can be spent on health, referred to as resource generation, to pay for health services, referred to as financing, and to govern and regulate the health system, which is referred to as stewardship. The World Health Organization has also developed a framework for considering the different parts of health systems and the roles that they play in health systems performance. And the framework has these 6 building blocks. The first one is good health services delivery, so delivering safe and effective health interventions. A healthy workforce, which has the appropriately number of trained staff in the right fields in places where it's needed. A health information system where it delivers the information needed for monitoring health status and health system performance. Medical products, so a health system should ideally provide equitable access to medical products, vaccines, and technologies. An effective health financing system, and one that it raises enough money to fund an agreed upon health program and protect individuals from financial harm. And then leadership and governance. So, the concern about the management, oversight, and regulation of health systems to maximize health for the money that's spent. And what we want to see is good access, good coverage, quality, and safe care. And the overall goals and outcomes are an improved level of health and equity for all, responsiveness of a health system, social and financial risk protection for its members, and improved efficiency. So how are health services organized? Well, the manner in which health systems are organized is related to a lot of history and politics and the values of individual countries. Countries generally spend more money per capita on health as the incomes rise in a healthcare setting. So, for example, most low-income countries had fragmented health systems that include both private and public providers. Many middle-income countries have a system organized around a national insurance scheme, and almost all high-income countries have a national health insurance system, usually based on social insurance. And social insurance is a public insurance program that provides protection against various economic risks to their individuals. So, such as loss of income due to illness, old age, unemployment, that you will still receive health care even in those situations. This is one way to categorize health systems in a very oversimplified way. So this is providing 3 different examples of health services. The first one is National Health Service, which we typically see in the UK and Cuba. And this system has a relatively small private health sector. The government is the sole payer for healthcare and owns most of the healthcare facilities. It's overwhelmingly based on public insurance, and it's very much tax-based. The national health insurance system, which we have here in Canada and other areas such as France, Germany, and Japan, these services offer health insurance to all people for an agreed package of services. So as you recall with the Canadian healthcare system, there are certain things that are covered by OHIP and there's certain things that you can pay for privately. And so people often refer to this as social health insurance. Now, we also do have some private insurance, but largely it's very much government run. And then the pluralistic view or pluralistic systems are in the United States, India, and Nigeria. And these systems do have a public sector, but they have a very large for-profit sector, which play really important roles. And in some of these systems, the private sector dominates the system. And in all of them, it does play a very large role. I want to bring your attention to this column along here, health as a right. And so this is looking at universal health coverage. And so in the National Health Service and National Health Service and National Health Insurance, it's looking at, yes, fundamentally health is a right. Over in this system where you see such cases as the United States, India, and Nigeria, health is not seen as a human right, that it's a personal good that you would actually pay for. And if we go across here and look at ownership of facilities, in these two, the National Health Service is overwhelmingly public. the national health insurance, the vast majority is public, but there is some private not-for-profit. And in the pluralistic, it is yes, public, private, for-profit, and private, not-for-profit. But we don't see private for-profit in the other two systems. If we look at forms of insurance along here, you can see this one is overwhelmingly public insurance for their citizens. This one, again, is largely government, single payers like Canadian, but also some firms or employees working to provide some private insurance. So you as a nurse will probably have some private insurance. But in this area, it's mainly it does have some public insurance, but it's typically you need to buy it, buying that private insurance. And there's a lot of individuals that lack insurance. If we look at financing of insurance, in this category, it's overwhelmingly tax-based. Here in Canada, again, you know that it is tax-based, and there are some individual premiums that you can buy for insurance through ONA, for example, or the hospital will contribute to private insurance companies. And then financing of insurance over here, it's typically, yes, employer and employee contributions, but there's a lot of individual purchase of insurance and out of pocket. So what are primary, secondary, and tertiary healthcare, and what services are generally rendered at each level? So health systems, as I've said, are typically organized into 3 levels. So in most high-income countries, primary care is provided by a physician, or in Canada, a nurse practitioner, and that is the first point of contact with the patients. And so in many of our systems, similar to Canada, any non-emergency patients must be seen by a primary care provider before they can be treated by a physician. And so these providers are typically referred to as the gatekeeper. Secondary care refers to care that is provided by physicians and typically in general hospitals, which are located in smaller towns and cities. And then at these physician services and hospitals, one would get treatment for kind of more common illnesses and conditions, and they can include emergency procedures and other procedures that maybe primary level providers can't do in their own, let's say, community clinic. And then tertiary care is provided in more specialized hospitals that are generally located in larger cities. And these specialized hospitals are typically staffed with a variety of physicians and healthcare providers, and they can address more higher level conditions with more higher level diagnostic treatments and surgeries. And we typically see these 3 areas, primary, secondary, and tertiary, usually part of universal health care. Now, the issue is that in most low-income countries, primary, secondary, and tertiary level facilities are really determined by the geographical area that you're in, the population size, whether there are actually any providers to provide this, and they're often very fragmented. And that is, if we were to think about one area that needs to be really improved to improve low middle income country healthcare systems, it would be implementation of primary healthcare, and we'll speak to that. So these are just selected examples of health services by level in a low income country. And so if available, primary level would include family planning, so a lot of maternal and newborn baby care, a lot of childhood, looking at simple treatments for adults and diagnosis of treatment of communicable diseases. Secondary level would have more obstetrical care, the diagnosis and treatment of sick children, maybe some minor adult illnesses, maybe some basic surgical services. And then tertiary level, if at all available in these countries, would be more complicated cases and more specialized services such as surgical services and advanced emergency care. But I would tell you that the majority don't even have a primary level care, which is really important. So this is a really important piece in global health. If we are going to get anywhere near universal health care, we need to think about primary health care. And so one of the most historic and core ideas about health systems is this notion of primary health care. And this came from a very historic conference back in 1978 in Alma, Ata, where many countries from around the world, I think it was about 179, I want to say, came together and spoke to global health and how could we reach health for all. And what came out of this primary health care conference of bringing everyone together was the Declaration of Alma Ata. And so the declaration has two important pieces to it. The first one speaks to health as a human right. And it looked to the unacceptable levels of health disparities that was seen in the world at that time, the important need for social and economic development, so thinking about those social determinants of health to be able to enable better health, and also speaks to people's right to participate in the planning and the implementation of health, so really taking a community focus. And it set the goal for health for all by the year 2000. And it outlines this concept called primary health care, which is different than primary care, meaning first level care. So primary health care was very broad in its thinking. So some of the characteristics of primary health care was that it was essential and socially acceptable. It was based on evidence and universally available. It addresses the needs of the community and is affordable. It provided the whole continuity of care, so preventative, health promotion, curative, rehabilitative services, and it was linked linkage to other health systems through a referral system. And it also looked at linking to other key determinants of health, including health education, water and sanitation, and nutrition. In October of 2018, a global conference on primary health care was again held to celebrate the 40th anniversary of the Declaration of Alma Ata. In countries around the world, again, examined steps in furthering the agenda for primary health care globally and the attainment of universal health coverage. And so, again, Alma Ata Declaration was reaffirmed by ensuring that the goal was health as a human right, the importance of primary health care as really the foundation for achieving better health, the importance of taking an integrative approach to enhancing health and looking across that continuum of care from health promotion and prevention to palliative care, the really importance of making greater progress in reducing inequities in health, and for this time around the greater focus and attention on the growing burden of non-communicable diseases. So I'm going to move us on and look at the different roles of the public, private, and NGO sectors in our healthcare system. So the public sector is responsible for the governance of the system, so stewardship, raising the funds for the health system, making decisions about allocating those funds, and establishing approaches to health insurance. And so the approaches to health insurance would refer to as, financial protection from health costs, as well as other things as setting up public health policies, enforcing laws, disease surveillance, food and drug regulations, and so on. Private for-profit sector. Most people would believe that health is a human right and should not be for sale. But the private for-profit sector is involved in the provision and financing of health systems in many different countries. And so it's involved in the provision of services, including non-licensed medical practitioners everywhere. It's involved in the operation of health clinics, hospitals, services, and laboratories. It can partner with the public sector or work under contract to the public sector. And as I said, it is essentially involved in all countries. And then what do NGOs do, which are private, but they're not for profit sector? And so they're often involved in community-based efforts to promote health through education, improve water and sanitation. They often carry out different health services, and they can partner with the public sector or work under contract to the public sector. So, what types of countries tend to have a larger share of private expenditure on health than public expenditure on health, and why? Well, there's a wide range in the share of total expenditure on health that is private sector expenditure. It's found that the less developed the insurance system is, the more there will be out of pocket and private insurance. So, obviously, in your lower middle income countries. Private health expenditure as a share of total expenditure is seen here. So in Denmark and France, only 15 to 25% is private. In Ireland and Israel, it goes up a little bit higher. And then in Bangladesh, India, Kenya, and Pakistan, you can see that 60 to 70% is private insurance. So you can see the importance of having a publicly funded health insurance that takes some of the onus off individuals for paying for their health care. What proportion of countries' GDP do countries spend on health, and why is there such a wide range? Well, GDP is a monetary measure of the market value of all the final goods and services produced in a country. And it's often a metric used for international comparisons between countries and their economic progress. So it really does vary across countries. Some countries spend a small amount, such as Indonesia, Pakistan, and Nigeria, but they do have not great health outcomes. Most higher income countries spend between 8 and 11 and 12%. Canada spends 11.5%, and the US spends 17%, but they have very poor health outcomes. And so it's really important to find that balance between being a healthcare system that's efficient, that's effective, and has really good health outcomes. So the last piece I want to speak to and I want to spend a little bit of time on are what are some of the significant issues that arise in trying to govern health systems in low and middle income countries. So in general, we would say that health systems in high income countries perform better than those in low and middle income countries. But really, all systems around the world struggle with a variety of challenges and constraints, including governance, financing, the human resources, access and coverage of healthcare services, and the quality of care that they provide. But there's some key healthcare sectors or health sectors that I want to speak to. And these are the ones that we'll touch on as challenges. And then in the next lecture, we'll look at some ways to address these challenges. So you've learned already when we spoke about the global burden of disease is that people are living longer. So societies are facing a greater burden of non-communicable diseases, and the cost of treating these communicable diseases is very high. And poorer countries actually are having a simultaneous triple burden of disease, which is communicable diseases, non-communicable diseases, and injury. And we see this through the demographic and epidemiological changes, and we've discussed that before. So that's one big challenge. A second challenge is stewardship or governance. High-income countries have clear rules and they can enforce those regulations, but low and middle-income countries have a lot of problems with governance. Weak governance tends to penalize poor people, and in particular because they have less power and less choice. There's weak management of human resources, and there's poor facilities, there's an increase in absenteeism, and corruption seems to be paramount, which causes many problems. Human resource issues can be a huge issue for low middle income countries. We see for sure in high income countries an imbalance in the types of personnel, but the poorest countries don't have enough healthcare personnel. And these individuals may not be paid as well. They're poorly distributed across large, vast geographical areas. They're poorly trained and motivated. And the human resource problems are compounded by brain drain, with individuals leaving low middle income countries where they're desperately needed and moving to high income countries through brain drain. The quality of care. So health services should be safe, effective, patient-centered, timely, efficient, and equitable. But we can see that there are differences in the quality of care between countries, among countries, and within systems. And these causes can include poor management, so back to stewardship, lack of financial resources, poorly trained staff, unempowered patients, so they just don't have the power to advocate for themselves. And oftentimes there's no system for monitoring the performance of the health system. Financing of the health system is huge. So high-income countries, they have issues with respect to rising costs due to our aging population and the use of new technologies. Low and middle-income countries have a lack of public sector financial resources for health. And so a lot of it is paying out of pocket or private that you must pay for. All countries need to spend time to develop more cost-efficient healthcare systems. I think one of the biggest barriers is financial protection and the provision of universal coverage. The capacity of people to pay for health services is a barrier to their access to care, and catastrophic health costs impoverish people in many settings, and I've seen this in my work in northern Ghana. In most high-income countries, this is not a significant issue because they have national health insurance or social insurance schemes. However, lack of financial protection is a common problem in poorer countries. And I've seen this in northern Ghana, where it's a leading cause of families falling below the poverty line or going even deeper and deeper into poverty. And it's a major cause of families selling assets to pay their bills for healthcare or not having any healthcare at all. And so it's really important that we look at financial protection for individuals so they can get the help that they need, and really looking at the provision of universal health coverage. Lastly, I want to speak to access and equity. So we've learned in this course so far that health disparities are an important feature of many health systems. And so it's important to look from the perspective of assessing health status, assessing the provision of health services, and looking at health outcomes from a point of view of their gender or sex, age, ethnicity, income, education, and location. So looking at access and equity. In low and middle income countries, disparities in access to services and inequities are often reflected in the following ways. And so, for example, the first one is a lack of coverage of basic health services in areas where poor, rural, and minority people live. That's been seen. Service coverage with a lower level of inputs in the areas previously noted compared to other areas, such as fewer trained personnel and less equipment and less drugs. So if you're living in an area with poor rural minorities, you tend to have a lower level of inputs or health services into these areas. Service coverage also varies with respect to immunization programs, with income and education levels, as well as location, with urban dwellers getting preference. And then lastly, better off people seem to get access to relatively expensive services that are generally less available to lower income and socially marginalized group. And so again, looking at this unequal access to many services based on health disparities. So I'm going to end there, and we're going to come back and look at what are some of the most important steps that can be taken to improve the effectiveness and efficiency of weaker health systems in low and middle income countries.